I just want to say thank you on behalf of all of us here in the forum, those of us at this workshop. And I think we are very lucky to have Tom at the helm of NIMH, that kind of calm, steady, thoughtful approach to actually solving problems and tracking our progress is going to continue to yield big advances. And we look forward to working with you as you go forward with this agenda. Thanks again so much. Let me turn it over to Peggy, and Peggy will introduce Vickie, who will help dispel some of the confusion with some clarity about definitions.
Thanks, Mark. I will come up for some of my introductions, but I think for right now, to save time, I'm going to do it from here. And, you know, one of the things that the Planning Committee struggled with most was in this section that we're starting now and understanding the problem is the idea of terms, because it is not an easy thing to do, and we've done the best that we think we could collectively. You know, when we're trying to understand the problem, we know we have to come to a common understanding of terms, describe the risk and protective factors that come into play, as well as the identification of significant neurocognitive mechanisms related to violence. So this session will be divided into 3 parts. And we're starting with Dr. Mays, who is a professor in the Department of Psychology at the College of Letters and Sciences, and professor in the Department of Health Policy and Management at UCLA. Her research primarily focuses on the mental and physical health disparities affecting racial and ethnic minority populations. And other areas of her research include looking at the role of perceived and actual discrimination on mental and physical health outcomes, particularly as these factors impact downstream disease outcomes. So, Dr. Mays, who's a member of our planning committee and one of the most vocal people on making sure we get the definitions right, is going to lead this session.
Thank you for that introduction. Following Dr. Insel is a hard act, but my task is very different. It's my pleasure to present on behalf of the Planning Committee some working definitions. I think as we started when Mark was saying, this is pretty important for us to try and have some common operating space here. So we thought we would do this early in the life of the meeting as a way to kind of get us started. Our assumption is that as people have differing definitions, they'll be clear about that, so that as we kind of get to the end of this, we all can hear each other and have some common language. Now, one of the reasons for taking the time to do this is that there's really a lot of confusion. I think we're dealing with some ambiguity, as you could hear in previous presentations, and even some issues about miscommunication. Let's see, am I going the right way here? Are you changing my slides, or am I changing my slides? Oops. Okay, thank you. And part of why that is that even when we use a term as simple as mental health, some people are thinking mental health is mental illness, some people are thinking mental health is on the side of well-being. So what we thought today is that particularly given the valiancy when we talk about violence and mental health, that what we would try and do is to stick with some definitions and see if we can kind of agree upon using these as our way forward. So we're going to start here by talking about mental health. And as you can see, what we're talking about when we say mental health is we're really going to be focusing on the issue of well-being. And thinking about that well-being in terms of the individual being able to realize his or her own abilities, that they can cope, for example, with the normal stresses of life. So you're going to see we're going to be on the much more positive side, and we're, you know, invoking the WHO definition here. Next. Now, on the other side, when we're talking about mental illness, the first thing we have to say is there's no one encompassing definition. I actually worked here at St. Elizabeth's Hospital in the John Howard Pavilion doing assessments of people who had committed crimes. And as a psychologist, my task was to do an assessment and to come up with what the disorders were. But I also had to learn how to do that within the context of legal definitions and making sure that I could walk into a courtroom and give information about what an illness was, but also the context in which that illness is occurring. So part of what we have to understand is that when we talk about mental illness, it depends upon where we are coming from and what our perspective is. But the goal today, despite the difficulty in the definition and not having a perfect one, is to really try, as Dr. Insel said, we need to have research that gives us better predictors. So what we want to be able to do is to identify risk factors in order to be able to prevent violence, to intervene earlier, to understand what better policies, programs, and practices are. Next slide. Here, the issue of serious mental illness, this probably is one that we can have more convergence on. We're kind of together on what the disorders are that typically fall into this, and they are the biggies in terms of major depression, schizophrenia, bipolar disorder, OCD, panic disorder, and PTSD. Part of what we know about serious mental illness is how disruptive it is. It's disruptive not only in the life of the individual, but typically it's disruptive within the community in general, for people, for their family, and sometimes in the broader system. The positive side of this is that there are treatments. Part of what we think about are not just medication, but therapies, but also what we have to think about, and I think that's where we'll go in terms of some of the policies, or what the program should be and what the policy should be to make sure that those treatments and medications that we have can actually get to people. But in terms of serious mental illness, we need to remember that recovery is possible when we can get these treatments to people in a effective manner and in a timely manner. Next one. Here, again, part of what I want to make sure that we do is to not just like kick this definition to the side just because it says DSM-5. I know that we all have different perspectives about DSM-5, so the goal here really is to just take the definition. We're not asking you to take the whole system at this moment, but instead to give us the opportunity today to use the definition of what a mental disorder is in terms of thinking about it as a syndrome, thinking about it as being characterized by clinically significant disturbance. I think we probably all agree, regardless of what our system is, in the areas of that disturbance being cognition, emotional regulation, or behaviors resulting in people being dysfunctional. So again, let's not kick the baby with the bathwater just because it says DSM-5, but we thought that this would help us to be able to operate fairly consistently in the same space by using this one. Next one. In thinking about the notion of violence, I kind of struggle with this myself, but this is the WHO one, in the sense of I wanted to make sure that the kind of emotional side was there, but I think the description does as well as a operating procedure going forth, where we're talking about the intentional use of physical force or power, threatened or actual. I'm going to read this one because it's important for us today. Against oneself, another person, or against a group or community that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. So I think it's important to see the depth and the broadness of this definition in terms of thinking about where we need to get in terms of what we're trying to reduce today. Conduct disorder. Here is, I think this is important for us in terms of bringing up conduct disorder because of when it occurs. What we're talking about typically is a group of behavioral and emotional problems that begin either in early childhood or in the teenage years. And again, I think what Dr. Insel was saying, part of what we need to do in terms of dealing with some of the mental disorders is thinking about intervening earlier. And sometimes what we tend to do is to see behaviors, to assume that people are going to mature and grow out of them, and not necessarily recognize their relationship to sometimes more severe behaviors. So what you see in children with this disorder is that they tend to have kind of long-term continual patterns of behavior, and you can see the way that this behavior tends to impact others, violates the rights and feelings of others, also goes against what's deemed, and I hate using the word normal, but kind of what's kind of typical by society for their age group. Next one. Here you begin to see kind of what the experience is of people in terms of thinking about conduct disorders. So you're going to see disruptive behavior, you're going to see rule breaking, but at the same time, when you see these behaviors, they can be associated with some other disorders, such as attention deficit hyperactivity disorder, childhood depression. You might see this in individuals who have suffered either physical or sexual abuse, and you can even see in terms of hearing loss. So again, when we think about something like conduct disorder, the behaviors that you're going to see could be, from a multiple sources, and so we can't jump to conclusions too quickly, but we have to think about, before we diagnose conduct disorder, what some of the other issues may be. So before we label too quickly, we have to also investigate kind of physical, family, school, social factors that may be contributing to this behavior. Okay, next one. Again, you're going to hear today research in which you're going to see kind of the role that substance abuse can play. And so we wanted to have a few of our operating definitions also bring this into play. Here what we're talking about is alcohol use disorder. And here what we're talking about is that it is clinically significant. We're not talking about the fact that a person has a drink and then, there's some, something that happens. But typically what we're talking about is a pattern. We're talking about that this clinically has significant impairment or distress. Diagnostically, you're going to see a kind of cluster of behavioral and physical symptoms. You can see withdrawal, tolerance, and craving in terms of this. Next one. Typically in DSM-5, we begin to look at it in terms of whether it's mild, moderate, or severe. Next one. Here what we're looking at is substance use, and here we're talking about illicit substances. And again, when we're looking at substance use disorder, what we're thinking about is a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite the problems that they experience as a result of using that substance. Next one. Here we're getting into the issue of perpetrators, and I think this is probably, the most significant thing that I want you to do is to remember the issue of balance. When we talk about perpetrators, typically what we're talking about is the person who has actually committed the crime or who is responsible for it occurring. But we often forget about the other side. And the other side is sometimes the reason that we have this person in this role of being a perpetrator is that they sometimes have been a victim themselves. They have been bullied. They might have been the victim of some kind of traumatic experience or crime. So we need to remember that in terms of this particular category. The other issue is most of what we see about perpetrators is often dealt with within the context of legal definitions. And what we're missing, which is what we hope we're going to get to today, is a little bit about kind of the why here. We need to develop a better understanding of the perpetrator as well as understanding what we can do in terms of that perpetrator's behavior being able to be predicted better, sooner, and earlier. On the other side, we have the victim, and again, some of this is the legal issues that we have to deal with. But when we talk about a victim, we're typically talking about the person themselves being harmed as a result of the commission of an offense for which restitution may be ordered, including in the case of an offense that involves as an element a scheme, conspiracy, or pattern of criminal activity. Any person directly harmed by the defendant's criminal conduct in the course of the scheme, conspiracy, or pattern. Again, it's very much of a legal definition, but it's like our goal should be in terms of thinking about victims is what is the range of interventions that we need in order to make a person whole and to be functional again in society. So I think that should be our last one. Yes. So let me stop here, take any questions or comments. But this, again, the goal of, thinking about this is not just that what we're doing is giving you kind of marching orders, but part of it is we're coming here from very different perspectives. And what we're hoping is that by listening and hearing each other, that what we will be able to do is to communicate better in order to come up with policies, procedures, and practices that are going to offer some new ways forward today.